Hello and welcome to another Facebook Live broadcast with MedStar Health. My name is Sarah Ridenour, and today we are talking about hypertrophic cardiomyopathy, the most common genetic heart condition. I'm joined by two HCM experts, Dr. Sandeep Jani, Director of the HCM Clinic in the Baltimore region, and Dr. Patrick Bering, Director of the HCM Clinic in the Washington, D.C. region. We're going to discuss the risk factors, symptoms, diagnosis and treatment, and more for this condition. So stick around, give us a like to let us know you're watching, and share this broadcast with your friends and family. And if you have any questions for our experts, feel free to ask those in the comments as well. So before we get into the questions, thank you both for joining us today. We really appreciate it. Before we get into the questions, could you both go ahead and give us another brief introduction of yourselves and the work you do here at MedStar Health? We'll start with you, Dr. Jani.
Yeah, I am an advanced heart failure cardiologist. So I see people with heart failure and all forms of various cardiomyopathies, including hypertrophic cardiomyopathy. And I direct the Hypertrophic Cardiomyopathy Clinic at Union Memorial in the Baltimore region. And I'm part of the heart failure team.
Great. Thank you so much. Dr. Bering?
Hi, hello. I'm Patrick Bering. I am a clinical cardiologist and cardiac imaging specialist here in the DC region. I primarily operate out of Washington Hospital Center. My imaging expertise is within echocardiography and cardiac MRI, and I'm the medical director of the Hypertrophic Cardiomyopathy Clinic here, where I see both patients, family members, and those who have suspected hypertrophic cardiomyopathy for this purpose.
Great. Thank you so much. So getting into the questions, first of all, Dr. Jani, what is hypertrophic cardiomyopathy?
Yeah, it's an important question, right? I'm going to start with the second word, which is cardiomyopathy. So if we translate that term, cardio means heart and myopathy means muscle problem. So cardiomyopathy is a broad term for a heart muscle problem. Now that's underneath cardiomyopathy, there's lots of different kinds, one of which is hypertrophic. And so hypertrophic, if we translate that term, hyper means lot and trophic means thick. So it's a thick heart muscle. So literally hypertrophic cardiomyopathy translates to thick heart muscle. Generally, we consider this an unexplained thick heart muscle or a genetic thick heart muscle that isn't related to another cause like valve disease, another type of cardiomyopathy that makes the heart thick, or really poorly controlled high blood pressure or something like that.
Okay, thank you. And so Dr. Bering, how is it diagnosed? Can you talk about that process of who diagnoses it? Is it a cardiologist, primary care doctor? Can you talk about the diagnosis part a little bit?
Of course. The most common way that it's diagnosed is through a diagnostic test. And the most common test for that is an ultrasound of the heart called an echocardiogram, or echo for short. This test uses ultrasound waves to take pictures of the heart, and it can see where there are areas of the heart muscle that may be thickened and what physiologic characteristics may come with that, whether that comes in one of the two more common forms called obstructive hypertrophic cardiomyopathy or non-obstructive hypertrophic cardiomyopathy. As far as who is diagnosing that, it's most commonly done by a general cardiologist. However, sometimes the diagnosis can be made by a primary care or family physician who orders the diagnostic tests. In addition, abnormalities are often present on the electrocardiogram or ECG, a test of the electrical voltage of the heart, including its rhythm and speed and any other electrical properties that may be normal or abnormal. And we usually do both of those two things together because they give additive information. But again, the most common ways that HCM is diagnosed is with an electrocardiogram and an echocardiogram.
Okay. And so you mentioned two different types of HCM. Is there more types or is it just those two? And could you go into a little more detail about the two?
Absolutely. One of the interesting things about hypertrophic cardiomyopathy is how varied it can be from patient to patient. Even among family members who have this condition, who may have a similar genetic basis for it, it can have variable different appearances and manifest in different ways. So the most common forms are obstructive, meaning that there's some impairment of the way that the heart empties its blood with each pumping function, which we call systole, or each beat of the heart. And non-obstructive, meaning that there's not an impairment or there's no obstruction to the emptying of blood from the heart. But in both cases, the underlying condition is due to this abnormal thickening of the heart muscle that's not explained by any other condition, as Dr. Jani pointed out. In patients with hypertrophic cardiomyopathy, about 2/3 are obstructive, meaning that there's some impairment to the outflow or emptying of blood. 1/3 of those patients will have obstruction at rest, and about 1/3 of patients who have obstruction may need some kind of provocative maneuver, whether that's a maneuver that we can do in the clinic with squatting and standing, or a specific kind of bearing down maneuver called a Valsalva. Or very often what we'll employ is something called exercise stress, where we have people do some exercise on a treadmill and then use Doppler ultrasound in order to evaluate for obstruction. Again, that last third is the non-obstructive form of hypertrophic cardiomyopathy, where there's no obstruction to blood flow, but there may be other physiologic consequences that come from the abnormal thickness of the heart muscle. And the reason that's important to differentiate between the two forms is that there are certain treatments that are available to patients with obstructive hypertrophic cardiomyopathy that are not necessarily available to those who have non-obstructive hypertrophic cardiomyopathy.
Okay, thank you for explaining all of that. So what exactly causes HCM, and are certain people more at risk of developing it? I know, as I mentioned in the introduction, it's the most common genetic heart condition. So can you talk a little bit more about the causes and who is more at risk?
Yeah, so it's an inherited heart condition, meaning that it tends to run in families and it has a genetic basis. We're not always able to identify a genetic cause with our testing, and we can get into that a little bit more later. But even in those cases where we aren't able to identify it, it's still considered an inherited condition. And again, when we look at a thickening of the heart muscle, we try to identify, are there other things that can cause it? Because there are other common conditions that can cause the heart muscle to thicken. Those include things like high blood pressure or certain valvular problems of the heart. There are some rarer forms that are not super rare, but can also be seen in our patients in the community who have thick heart muscles, things like cardiac amyloidosis that can cause this condition, and then some even rarer forms of inherited heart disease where there's a problem with metabolism of certain substances in the body and how those get stored in the heart muscle. Those are called phenocopies, or we'll call them mimics of hypertrophic cardiomyopathy. But if we're talking specifically about hypertrophic cardiomyopathy, that's a disease of the heart muscle where certain genes that are involved in building the structure of the heart muscle may be mutated, and that can cause it to thicken in certain ways. So the underlying cause is primarily a genetic cause, although there is also an interplay between the genetics that a patient may inherit, as well as the things that their body is exposed to over time. So you asked things about, are there certain patients that are more at risk of developing hypertrophic cardiomyopathy? Well, we know, as I mentioned, that there is an interplay between the genetics that we inherit, as well as our health behaviors and those health problems that we may acquire as part of our lifestyle. So for example, patients who have high blood pressure are actually more likely to develop a thickening of the heart muscle that's more prominent if they have an underlying genetic predisposition to that. The same thing goes for conditions like diabetes mellitus or obstructive sleep apnea. Those patients who have these these other health problems may have more progressive or significant forms of hypertrophic cardiomyopathy compared to their family members who don't have these other health conditions. And so, like many things in cardiac disease, We often advocate for our patients to maintain a very healthy lifestyle because that often helps with their overall symptoms and quality of life, as well as their risk of developing this heart condition in a more significant form.
Right. And then at what age do people typically start showing signs of having this? Is there a, certain age range, or does it vary from person to person?
That's one of the interesting things about this, is that it's very variable.
Okay.
Some people may develop signs and symptoms of this heart condition at a young age, in childhood. Many people develop it in early adulthood, and we do know that there is an influence of things like sex hormones and puberty on the thickness of the heart muscle. And so some patients may develop signs and symptoms of this in early adulthood or just after puberty. Other patients may live much of their life without knowing that they have this condition and first be diagnosed with it in their 5th, 6th, 7th decade of life. The oldest patient that I have who had this as their first diagnosis was diagnosed in their 8th decade of life. And so it is something that can be variable among different age groups, but it's always something that we should keep in mind. Many of our cases occur more in early to mid adulthood, but we see it at a variety of age ranges. So just because a patient may be in later adulthood doesn't exclude this as a potential cause of their symptoms.
Right. Okay. Thank you for explaining that. And Dr. Jani, how can someone tell, that they have HCM? Speaking of, you just mentioned you can show symptoms at any age, really. What are those symptoms people should look out for before, that maybe is their sign that they need to go see an expert about this?
Yeah, Dr. Bering, said a couple of times that the HCM is variable and the symptoms are variable as well. There are many people who have basically no symptoms and get diagnosed incidentally. They get an EKG because they needed to have surgery, or something else comes up and they happen to get a test on their heart for some other reason and we find it. So there are patients who are asymptomatic and are incidentally found. There are people with mild symptoms, which may just be some very slight shortness of breath. I had a patient who was very active, but when he rode his bike up one specific hill, he would get short of breath, or when he was at peak exercise, he would get more short of breath than he thought he should. Some people will have palpitations, meaning they feel like their heart is racing. And then people can have more severe symptoms as well, like severe shortness of breath, where a year ago, they could do everything they could do in their life without a problem, and now they have difficulty walking up a flight of stairs or walking around a grocery store, or they develop leg swelling, or they get dizzy or pass out for unexplained reasons, or they have chest discomfort for reasons that are unexplained. So these are all symptoms people can have, but it can be highly variable, and people can have virtually no symptoms or no symptoms at all to very severe symptoms. And in an individual patient, it can be variable. Some patients may have worse symptoms in the summer because they're less hydrated than they are in the winter. And so some people will have symptoms after they eat a heavy meal, for example, as opposed to when they don't. So even in individual patients, it can be variable.
Interesting. Oh, sorry to cut you off. Go ahead.
But the symptoms are what cardiologists call nonspecific, or what doctors call nonspecific, which means that people understand that something may not be right, but a lot of things can cause shortness of breath and palpitations and dizziness. And it's usually the testing that makes the diagnosis.
Right. Okay. Yeah, no, sometimes, if you're out of breath, it can be easy to just say like, oh, well, I'm out of shape. Right. Even if, like your example with your one patient, he was very active and just had trouble with that one hill. That's his sign that, all right, maybe something's wrong. Maybe something's not right here. So kind of going along with, you mentioned describing how patient symptoms can be different. So I assume that means there's different degrees of severity just throughout, anybody who has HCM. And what does that mean for them specifically, like based on, I guess, the patient's degree of severity? How does that affect their lifestyle? And can that, is that something that can change over time too, their level of severity?
Yeah, absolutely. Every HCM patient, I tend to think about several things. The first is obstruction, which is what Dr. Bering brought up, where is an impediment to flow from your heart to your body. And that happens frequently in patients with HCM, roughly 2/3 of the time, as Dr. Bering mentioned. And so we're always on the lookout for that. That can make people short of breath, that can make people dizzy, that can cause chest discomfort. And if that's present, then there are ways to deal with that that could potentially make people feel better. People can have different degrees of obstruction. It can be mild or severe. And even in that setting, what we see on the pictures doesn't necessarily correlate with their symptoms that they have. And so some people with what looks like severe obstruction on, the echocardiogram that we do may have very mild symptoms and vice versa. The symptoms can vary and the degrees of severity and obstruction can vary. The second thing I always think about is the risk of electrical problems with the heart. And people can develop electrical problems in the upper chambers of the heart, such as things like atrial fibrillation or other heart rhythm issues from the top chambers of the heart, which are important and need to be managed appropriately, but aren't necessarily life-threatening. And people with HCM can develop fast heart rhythms from the lower chambers of the heart, from the chamber with the thick heart muscle. And that can be life-threatening potentially. And so we have ways of, with all the testing we do and with family histories and their symptoms, to understand, is someone at a high risk for having a dangerous heart rhythm problem, or are they not? Okay. And if they are at a high risk, then we start talking about implantable defibrillators, which is kind of like a little pacemaker that is a life insurance policy or watches. And if people have a dangerous heart rhythm, it goes into action to get them out of it.
Okay, interesting.
Some people develop heart failure symptoms, so we're always on the lookout for heart failure, and those symptoms can be mild to severe. And then, the important thing is that this can vary over time. So we do repetitive testing over the course of time to understand, is the heart the same as it was last year? Are the heart rhythm issues the same as they were last year? Has something changed? Are your symptoms worse? Are you able to exercise as much as you were? And then we sort of address our treatment strategies to how they're feeling at that moment and what their heart looks like at that moment.
Okay. Well, thank you for explaining that. Yeah, and we'll talk more about treatment later. And but you mentioned exercise. My next question has to do with exercise and maybe more specifically athletes as well. If you have HCM, does that automatically mean that you should limit strenuous situations like sports? And then if an athlete is diagnosed, does that mean that they should stop participating in sports, period? Or maybe certain sports they should stop and others they can continue going? Can you talk a little bit about that?
Yeah, so there's been a shift in thinking over the last several years about this. It used to be that if you had hypertrophic cardiomyopathy, we said you should not be exercising really at all. And now we've sort of shifted our thinking. So we tend to think that moderate exercise in most of these patients is fine. And so those are things like jogging, swimming, biking, things like this. So those are, for athletes, it becomes a little more challenging, and it becomes really a discussion between their doctors, the family and the patient, if they're young, and the teams that they play for. We tend to recommend against high intensity activities. Okay. So these are things like sprinting or things where they're burst activities, because we worry about, adrenaline sort of shooting up and causing heart rhythm issues and other issues. Now, saying that, for competitive athletes who are very competitive, it's really a discussion between the cardiologists and the teams in terms, and the patients, in terms of what the risk is, what risks the players are willing to take, what risks the teams are willing to take, how we mitigate those risks, and how do we manage that going forward. And I often rely on a sports cardiologist to kind of help me in those discussions, who can sort of navigate that field as well.
Okay, great. Thank you. And I think you might have touched on this a little bit earlier, but if you have HCM, is there anything you can do to stop it from progressing, with like lifestyle changes, maybe diet, things like that?
Not usually. I mean, I
Okay.
think, as Dr. Bering mentioned, there's an overlap with high blood pressure. So you want to make sure that the high blood pressure is controlled and your other sort of health issues are controlled. But beyond that, this is a genetic disorder most of the time, and through no fault of anyone's, the heart is going to do sort of what the heart is going to do as much as we think. We don't have great medications or data yet to suggest that we can stop the process,
Okay.
but there are certainly treatments available.
Great, thank you. And we do have a question from one of our viewers. Jessica is asking, what are some of the signs and symptoms? We talked about this a little bit earlier, but I think it's an important thing to, discuss again, to go over again, signs and symptoms that you might see that could lead you to go get checked out by a doctor.
Yeah, so things like shortness of breath that is abnormal,
Mhm.
meaning that you're unable to do what you used to do, and it's not just that you're out of shape or something like that. It's abnormal shortness of breath. Feeling your heart racing is another symptom. Chest discomfort is a symptom. Dizziness or passing out are symptoms. And then sometimes people will get leg swelling or inability to lay flat without getting short of breath. Things like that can be symptoms as well.
Great, thank you. And thank you for your question, Jessica, and thank you for tuning in.
Yeah, I would, if I may
oh,
jump in for a second, Sarah, sorry,
yeah.
I would echo exactly what Dr. Jani said. And one of the things that he pointed out earlier is that patients will often have their symptoms when going up an inclined surface. For whatever reason, that seems to be the most common thing that we hear from our patients, is that as they're walking on level ground, they feel okay. As soon as they start going uphill, they just feel tired and winded and they can't keep up with people around them. If they're going up a flight of stairs or 2 flights, they get very tired going up them, as opposed to in the past when they might not have had this, or if they compare themselves to others who might be climbing a staircase at the same times, they seem to lag behind their colleagues or whoever it is that's doing that exercise and effort with them. So often going uphill and having that abnormal shortness of breath is probably the most common thing. Again, it's a non-specific symptom. As Dr. Jani pointed out, many of these symptoms don't necessarily point 100% to hypertrophic cardiomyopathy on its own. They may be due to a variety of causes, but seeking advice and potentially diagnostic testing from a healthcare professional is usually the best way to sort out what may be causing the symptoms.
Right, exactly. Thank you for adding that in. I think that's an important point to add. I'm going to take a second to pause and just thank our viewers. If you're just now tuning in, thank you for joining us. Today we're talking about hypertrophic cardiomyopathy, which is the most common genetic heart condition. And I'm joined by 2 HCM experts, Dr. Sandeep Jani, director of the HCM clinic in the Baltimore region, and Dr. Patrick Bering, the director of the HCM clinic in the DC region. We're discussing the risk factors, symptoms, diagnosis, and treatment of more of this condition. So stick around, continue watching, give us a like to let us know you're here. And if you have any questions for our experts, you can ask them in the comments below. Getting back into our questions, Dr. Bering, could you explain a little bit more the genetic component of HCM? Is it something if any member of the family has it, does that mean people should get tested who are also in the family? Can you talk a little bit more about that?
Yeah, so genetics is one of those things that we often take a lot of time to talk about with our patients, because as we pointed out, since this is an inherited condition, it can affect multiple family members or cross generations. Genetics can be a little bit difficult, but if we try to distill it down to some of its simplest forms, I think we can often explain it well. So we have a pair of each set of chromosomes, and because of that, we have 2 genes that encode for different proteins or serve different functions in the body. And in hypertrophic cardiomyopathy, in the way that it's inherited, which is called autosomal dominant, all we need is really for one of those 2 pairs to be abnormal for it to be passed from one generation to the next. And because the next set of the next generation gets 50% of their genes from one parent and 50% from another parent, that means that if one of the parents is affected by hypertrophic cardiomyopathy, there's a 50% chance that that gene gets passed along from one generation to the next.
Mhm.
Because of that, if a patient is diagnosed with hypertrophic cardiomyopathy, we do recommend genetic testing for that patient, the patient that we know has this heart condition. If the genetic testing is abnormal, not only can that inform whether or not we recommend genetic testing for family members that share 50% of their genes. For example, those are what we call first degree relatives. So parents, siblings, and offspring or children. And again, these are biologic relatives, so blood relatives. So we can recommend genetic testing of family members if genetic testing of the person who has hypertrophic cardiomyopathy is abnormal. And if they have the same genetic abnormality that our initial patient does, then we often know that we need to keep a close eye on them over time to see if they develop this heart condition. One of the interesting things about hypertrophic cardiomyopathy is that although it's an inherited condition that has a genetic basis, it doesn't always manifest itself even if someone has the genetic predisposition for it.
Okay.
So that means that even if someone has the abnormal gene that causes this condition or that may cause this condition, they may not develop it over their lifestyle. Now they can still pass that abnormal gene to the next generation, but we definitely want to keep an eye on them. And again, recommend a healthy cardiovascular lifestyle in any case, so that they have a lower likelihood of that interplay between the genetic predisposition and the development of the thick heart muscle condition.
Right, that's good to know. And you mentioned genetic testing. So my next question is talking about genetic counselors. What are they? What role do they play in the treatment of HCM? Do they do the genetic testing? Is that who you would go to get that done?
Absolutely. I think the role of a genetic counselor is essential when talking about inherited diseases. And since hypertrophic cardiomyopathy is an inherited heart condition, they play a really vital role in the management of hypertrophic cardiomyopathy, in empowering our patients with information about the condition, and helping to answer a lot of questions that people may have, things that may cause them anxiety, things that may cause them worry. I think in many cases, some of the fear that we have with the condition is a fear of the unknown, or a fear of a lot of the questions. And our genetic counselors are incredibly knowledgeable, highly trained individuals in human genetics who can give very vital information about what is the role of genetic testing. They can talk about things like reproductive counseling. They can talk about the pros and cons of genetic testing, because people do have some questions about, well, what does it mean to me if I get genetic testing? Will that affect my ability to get things like life insurance, etc.? Genetic counselors are full of very useful and practical information to help people understand what it means to have an inherited heart condition, what the results of the genetic test mean, and how does that potentially impact my first degree blood relatives. And so we work very closely with certified genetic counselors. And in the field of cardiology, we have ones that specifically work with inherited cardiac conditions. So it's very important that a certified genetic counselor be part of the treatment team for hypertrophic cardiomyopathy, because of the very important role that they play in distilling some of the complex information into very understandable bite-sized pieces.
Exactly. Thank you for explaining that. Dr. Jani, does having HCM increase the possibility for additional health conditions? And with that, could other conditions, can they cause or worsen HCM? I know we've mentioned high blood pressure a couple of times. But like I said, first of all, can it increase the possibility of additional health concerns?
Yeah, I mean, HCM is there are some conditions that are systemic, meaning they affect your whole body.
Mhm.
HCM tends to be specific to the heart. So it's not like, we start thinking about your kidneys having a problem if you have HCM or something like that. So primarily the issues we deal with and the complications are related to the heart. Now, saying that, some patients with HCM can be at higher risk for stroke, but again, it's mostly determined by what their heart looks like.
Okay.
And the high blood pressure is obviously interplays. We tend to, when we see patients with HCM, we tend to get a pretty thorough understanding of all the components of the heart, including the blood supply and the electrical system, the muscle, the valves. We sort of look through all of it and get a pretty thorough understanding to understand if those things can impact other health systems, other parts of the body. But inherently, if you were to say, I have HCM, now I have to worry about my liver or something like that, that's not usually the way we would think about things.
Okay. Good to know. And we're going to talk about treatment in a second, but we actually have a question from one of our viewers that I think is probably an important topic to talk about. Edie asks, is there any correlations to HCM and COVID vaccines?
At this time, we have no known connection between them. Hypertrophic cardiomyopathy is a very separate thing. Again, as an inherited heart disorder, it's something that we are born with the predisposition for. We don't have any knowledge that the COVID vaccines will enhance that predisposition, meaning that if someone has a genetic likelihood of developing it, that it'll be more likely to occur with COVID vaccination. And indeed, many patients who have underlying health conditions have higher risks of complications if they get COVID-19 infection. And unless there's a medical reason not to, or if someone has a religious reason why they don't want to get vaccinated, we do have a strong encouragement for our patients who are at elevated risk of complications from COVID-19 infection to consider vaccination as a protection against severe illness from complications of COVID-19 infection. And thankfully, some of the newest iterations of the COVID-19 vaccine do protect against the more common forms that are circulating in our community now, the Omicron variants of COVID-19 infection. And so again, if a person is living with a heart condition, we know that that's one of the risk factors to have increased risks of complications from COVID-19 vaccine or COVID-19 infection. And so vaccination becomes a very important topic to consider for those patients. So thanks for the question. It's a really good one.
Yeah, I want to echo on that. And, I tend to tell patients that the risk of getting COVID, if you have a cardiomyopathy, basically any cardiomyopathy, the risk of complications with COVID is much higher than the risk of complications with the vaccine itself.
Okay.
And so I fully agree that vaccine is important in these patients.
Great. Thank you both for clearing that up, and thank you for your question. So like I said, getting into treatment, I'll ask you both this. What are the different courses of treatment for HCM that a patient can take? I'll start with you, Dr. Jani.
Yeah, so it's a lot of it is determinative on their symptoms and whether or not they have obstruction. So we look at several things. One is the obstruction. So we figure out, is it hard for the heart to get blood out to the body? Is that a challenge? And is that causing symptoms? And if so, then we try to tackle that problem. And the way we tackle it first is with medications, which include usually first line is something like a beta blocker, like metoprolol is a common one, though there are others. And if they still have obstruction beyond that, then there are new medications that are out called cardiac myosin inhibitors. That's the class of medications that can help to relax the heart to sort of allow the blood to circulate it a little better. If those don't work, there are other alternatives as well, such as procedural based alternatives like surgery to make the heart physically thinner, or catheter ablations, in which we have techniques to, if you will, sort of create a controlled heart attack to thin out the heart. So the obstruction is the first piece that we think about in the first sort of set of treatment algorithms that we go down. And it's really fundamentally based on the patient's symptoms and how severe the obstruction is in terms of their symptoms.
Okay. Dr. Bering, did you have anything you wanted to add on to that?
Yeah, I would echo exactly what Dr. Jani said. Again, one of the reasons that it's important to identify, does a person have obstructive versus non-obstructive hypertrophic cardiomyopathy, is that there are different treatment options available for the group that has the obstructive form, which again is about 2/3 of patients and sometimes requires things like exercise testing really to fledge out and identify, is it obstruction or inefficiency in the way that the heart is emptying of blood that is causing their symptoms. So again, the main things there are medical therapies that try to improve how efficiently the heart is emptying of blood, as well as procedural therapies, which we often call septal reduction therapies, that can help the heart empty of blood more efficiently. In addition, the non-obstructive forms, we often focus on ways that the heart can fill more efficiently, or and so we talk about making sure that a person again has enough fluid in their body but not too much fluid, and hydration is one of those really important key pieces that although it's not a medicine and although it's not a procedure to help people feel better, patients living with hypertrophic cardiomyopathy are often very sensitive to dehydration, especially. And so we definitely recommend that patients be well hydrated in their daily life. Many times what people think of as adequate hydration is usually not enough. We usually recommend up to about 4 quarts of fluid a day for some people with hypertrophic cardiomyopathy. And so that's a very important consideration when thinking about this, is that making sure you're well hydrated. Now, there are certain people with hypertrophic cardiomyopathy who have congestion from that, congestion of fluid in the top chambers of the heart or their lungs. And so they may be sensitive to the other thing, which is too much fluid in their body. And so it's important to figure out with their cardiologist, who should be familiar with hypertrophic cardiomyopathy, how do I balance my fluids? Am I the kind of person that needs to be very well hydrated with fluid, or am I the kind of person that needs just enough but not too much? And so that's an important seesaw balance to keep and talk about with your cardiologist if you have this condition. So again, although the primary treatments are either through medications or sometimes, if needed, through procedures, there are also some things that one can do within their lifestyle to make sure that they don't predispose themselves to feeling worse. Again, especially for patients who have obstructive hypertrophic cardiomyopathy, adequate hydration is very key. And eating too much can also cause you to feel worse. This is something Dr. Jani talked about earlier in our discussion. Really big meals and a full stomach often make people feel fatigued and sluggish, and may even predispose people to feeling lightheaded or dizzy or having chest pain. So we recommend drinking more and eating less overall for hypertrophic cardiomyopathy.
Great, thank you. My next question, Dr. Jani, what type of doctors should a patient see if they have HCM? Can you talk about that, and then maybe even go a little bit into like the journey that they could possibly go through from start to finish with their doctors?
So patients with HCM need a cardiologist. And I think we prefer cardiologists who have some experience with HCM. And one of the things that Dr. Bering and I offer is a sort of a full assessment and a full set of testing, including all the imaging that may be necessary, like echoes, stress echoes, treadmill echoes, MRIs, genetic testing, heart catheterizations when appropriate. So it's a whole series of stuff that an HCM patient may need. So they need a cardiologist to sort of spearhead all of that. They should also have a primary care doctor, generally to sort of manage the non-cardiac issues. And sometimes they have multiple cardiologists. Sometimes they have an electrical heart doctor. Sometimes they have an HCM cardiologist and a general cardiologist. And sometimes other folks may interplay in there as well. So that's sort of the minimum is a cardiologist and probably a primary care doctor, but it may go much more extensively than that.
Okay, thank you. So my last question for the two of you is just a way to, I think, a good question to wrap the broadcast up. What's the message you would like our viewers to take away after watching this today? Dr. Bering, I'll start with you.
Yeah, great. So thank you for having us here, and thank you all to those of you who joined us live on Facebook. Hypertrophic cardiomyopathy is a common condition, and it's the most commonly inherited heart condition. The symptoms are non-specific, and so it really takes diagnostic evaluation with certain tests to figure out if a person has it or not. One of the important things is that if you are diagnosed with this condition, is to seek out care with a team who has good familiarity in treating this condition. There are certain complex decisions that can be made about different treatment options, and sometimes those have a time-sensitive window. I don't mean like days or weeks, but sometimes there are sweet spots over certain years of a patient's life where certain treatments may have better long-term impact, when a person might be a candidate for it and they lose candidacy for certain treatments later in life. And so being involved with a team who has very good experience treating hypertrophic cardiomyopathy, like we offer at MedStar, both in our Baltimore campus as well as our Washington campus, I think that's one of the key things, is to advocate for yourself as a patient. Seek out a team who knows how to treat this condition and can offer you the comprehensive care which we do.
Great, thank you. Dr. Jani?
Yeah, I think there's two or three key points I want to sort of bring up, some of which we emphasize, some of which we sort of passed over. One is that hypertrophic cardiomyopathy is actually fairly common. And we find more and more people as our diagnostics get better and better. And so we estimate somewhere between 1 in 200 to 1 in 500 people have hypertrophic cardiomyopathy. So the way I like to think about it is, if you imagine a football stadium on a Saturday or a Sunday, where there may be 70 to 100,000 people, several hundred people theoretically have hypertrophic cardiomyopathy in that stadium.
Wow.
So it's pretty common. The number two point is there's things that we can do to make people feel better, as well as to mitigate risk from the condition in experienced teams. And one of those things is a new medication, which I mentioned in passing, but there is a new medication that got FDA approved earlier this year that is specifically for obstruction. And it's the first medication designed specifically for hypertrophic cardiomyopathy. It takes some expertise to prescribe and to manage, but it does help people feel better. And I think we both have several patients on it at this point who are doing well and feeling better on it. So it exists, and finding an experienced team that knows how to navigate the sort of risks and the benefits of all these various options is a good thing to do. And the third thing is that patients with hypertrophic cardiomyopathy, when managed appropriately, can have normal life expectancies and good quality of life. And it's just about finding the right team that can assess it all, and getting the right testing, and then navigating the sort of treatment pathways.
I think that's a great positive message. I couldn't agree more.
Yeah, I was just about to say that's the perfect way to wrap this up. So thank you to our experts for joining us, taking time out of your day to sit with us and answer our questions. And thank you to our viewers for tuning in and asking your questions. To schedule an appointment with Dr. Jani, you can call 410-554-6550. And for an appointment with Dr. Bering, you can call 202-877-2183. We'll also be posting those phone numbers in the comments for you guys as well. Once again, thank you for joining us, and we will see you next time.
Thank you, everyone.
Thank
Have
you.
a great holiday season.